But the data is clear, Dr. Hyman, like on mental health, like you are better off giving her, balancing those hormones than giving her an SSRI. It is more effective for the perimenopausal patient with new onset mental health changes. I just refuse to let people suffer.
Welcome, Dr. Haver, to the Doctor's Pharmacy Podcast. It's so great to have you here with us today.
Thank you for having me.
You know, you are now a shining light in the field of women's health and menopause. You're everywhere, and you're talking about things that often have been neglected. And, you know, and when we went to medical school, we never learned that women were different than men. All the research was done on men, you know, and so we really kind of had this whole field of neglected suffering, that I would call it, that women endured without a lot of help. And it was like, take the pill or take Prempro, which is Premin and Provera. And those are like the two kind of options. And of course, I'm oversimplifying, but it was basically that. For if you have menstrual disorders, take the pill. If you have menopausal stuff, take Prempro. And there was like, that was kind of it. There was no discussion of diet, of lifestyle. You know, you have a background in culinary medicine. You know, people didn't understand the complexities that happen in women's health, the role of insulin resistance, the role of inflammation, the role of the microbiome, the role of toxins and endocrine disruptors. Like none of that was stuff we learned. And yet it's so important. And so many women suffer unnecessarily from symptoms that have simple solutions. And what's so great about your work is that you help people really navigate that and talk as a physician, but also as an obstetrician and gynecologist in a deep way about this. And you've also had your own personal experience as a woman. So that adds a lot of flavor. I mean, I'm just a guy and, I probably shouldn't be talking about this, but I think, my experience as a physician was sort of shaped by my work at Canyon Ranch, where basically for almost 10 years, I worked taking care of people between the age of 35 and 60, which was sort of the majority of women. And I learned a lot about issues. And it sort of struck me that so many women were suffering needlessly from things like PMS and, dysfunctional bleeding and menopausal symptoms and osteoporosis and mood changes and sexual dysfunction and just a whole bunch of stuff that just never got fair airtime in traditional medicine. So I kind of would love to sort of hear your perspective, just taking us through kind of let's call it your indoctrination. I'm not going to call it brainwashing, but it's kind of brainwashing. No. We learned a lot of good stuff in medical school for sure. And it's the foundation, but where did you get from what you learned there to where you are now? And how did you kind of shift your perspective, and what was the sort of the things that kind of catalyzed that change in thinking?
So I, again, traditionally trained, super proud of everything I learned. But as I grew older and my patient population was growing with me, we're all becoming perimenopausal and menopausal together. When I started out, I was having babies. My patients were having babies. You get all the new OB patients, in your early days in family medicine, you get that. And then you kind of get your set of patients and off we go together. So here we are, mid 30s, early 40s, and there's this litany of complaints that myself and my patients are starting to go through. And I thought back to my residency training where there's a very shameful story of I was a new intern with my little white coat in gynecology clinic, and the upper levels would run to the charts back when we had paper charts and shuffle through to find the surgery cases. They wanted the surgeries because they had to get their numbers to graduate. And then that kind of left everything else in gynecology for us. So that was discharge and irregular periods and all the things. And then the interns got the very end of the pile. And it's what my upper levels would call a WW. And I didn't know what that was. And they, so your upper level WW. And so they called it a whiny woman.
Oh,
and we didn't write it in the
really?
chart, and no professor ever said it. Other parts of the country called it whiny gynies. So women are coming in with these multiple vague complaints. They're all somewhere in their late 30s to 40s. They all have this kind of laundry list of very vague complaints: not sleeping, low libido, weight gain, tummy fat, that's new, not, just disrupted mood, disrupted relationships. And we were taught that, well, this is just something women go through. And there's not much we can do about it, and pat her on the knee and tell her to sleep better and lose weight and have some wine and everything will be okay.
Have some wine. Oh, that's going to fix it.
Yeah.
That's going to make it a lot worse, actually.
So fast forward 20 years and I'm sitting there, and it clicks in my head. I'm like, I'm a whiny woman. These are whiny. No, there's more to it than this. So that's where I started opening my mind, changing my perspective, and realizing, Dr. Hyman, that there is a huge gap in my own knowledge and training. And I would have sworn 10 years before that I was a great menopause doctor. I made A's on my tests, blew the top off my boards, but I didn't know what I didn't know. And so the more I dug and then started to grow on social media because I started talking about it, when 10,000 people tell you, my frozen shoulder started at, right when my periods became disrupted in perimenopause, I don't blow them off. I go look. It turns out we have evidence for multiple organ systems that are really attributed to, when the hormones start changing, all the things that can go awry, not just hot flashes and night sweats.
I think you're so right about that. One of the stats that just blew me away was that 75% of women have some degree of premenstrual syndrome or PMS, right?
Oh yeah.
And I said to myself, what's going on here? Like, this is not a design flaw. Like, whether you believe in, we were evolved from whatever, or God made us or whatever. Nature's not that stupid. God's not that stupid. Like, why are all these women suffering? It's not something universally attributable to being a woman. It's something going on in our environment that's driving these changes. And there's things that can be changed in women's behaviors and their environment and their diet and their lifestyle and toxins that will make a difference. And so I kind of was like, it kind of made me angry to see all these women who had all these issues that were not being dealt with effectively. So for you, when you kind of had this insight, what was the next step for you in kind of changing your practice? How did you start to kind of shift in your head to kind of think about this differently? And what did you do differently? What did you learn to do that you stopped doing? And what are you doing now that you didn't do?
So, kind of my toe in the water was my patients and my frustrations with what at the time I was calling the unexplained weight gain. Now I know it's a body composition change, but everybody was complaining of the same thing. And it was one of my, besides the hot flashes, night sweats, and joint pain that I was having, my pain point, having been a thin person most of my life and having that thin privilege, then all of a sudden not being able, despite no changes in diet and exercise. Actually, I was doubling down on really destructive behaviors, probably. Calorically restricting to ridiculous levels, doubling down
Oh,
at the
wow.
gym without any real results. And so finally, it was my husband, who's an engineer, who thinks very, and he's like, honey, your daughters are watching. So my kids were, teenagers and preteens at the time. And he said, you're getting up in the middle of the night to pee and I see you weigh yourself. This is not healthy. You're a scientist. Figure this out. So I called the nutrition department at the university I was employed at, and I was their doctor, right? So I called my friends who I delivered all their kids and the PhDs, and I said, "What is going on in menopause? Everyone's complaining of this." They led me down a rabbit hole of inflammation, how estrogen deprivation is related to inflammation. I'd never been taught this information in my life. It was never in our CMEs. It was not, menopause was hot flashes, night sweats, general urinary syndrome, and some osteoporosis. That's it. And I'm like, wait, this isn't my fault. This isn't because I'm lazy. This isn't because, and they're like, oh, by the way, this visceral fat deposition is leading to cardiometabolic risk that you never had before. What's your cholesterol doing? And having come from, I was a PCOS patient, had fertility treatments for my kids, learned that's where my toe in the nutrition space started, because I was on these online forums. Like I couldn't take enough metformin to, I'm like, there's got to be a better way. And that's where I learned about how nutrition is playing into this as well. And so, starting to talk to my patients about it, them getting excited, looking at changing our nutrition. Are you getting enough fiber? Are we getting enough, instead of counting calories, let's look at nutrients and see what happens. And that led to, the Galveston diet. And then, but then the conversation just exploded around menopause in general.
Yeah. It's interesting. I wrote an article years ago because I think, this sort of change in thinking happened to me too. It was called The Life Cycles of Women. And it was talking about all the changes that happen at different periods of women's life, when they're going through puberty, when they're in their 20s, their 30s, their 40s, their 50s, their 60s. And it really is different in every stage of a woman's cycle. And it's something that is not well appreciated by women. It's not appreciated by most doctors. And yet when you begin to understand the physiology and the biology of what happens, you can start to intervene and help people actually deal with some of the suffering. So your focus is mostly on menopause, but I'm sure you've dealt with PCOS, you've dealt with PMS, you've dealt with dysfunctional bleeding and all these things that happen. What do you think are the biggest causes for this sort of epidemic of hormonal dysregulation and suffering that women have to go through. That is, I would say, usually avoidable or preventable or treatable if it's not.
Right. So, definitely our nutrition. It's so much of it is the quality of our nutrition. Too much caloric intake for a lot of patients. Having when your body composition changes and you have these, you're leading to increased insulin resistance, which directly affects the function. The insulin receptors on the ovary, which leads to PCOS. So, I think nutrition, exercise, how we kind of move, how we think, how we eat as a culture is really pointing to a lot of the disruptions that we're seeing.
Yeah. So I don't know if this is true or not. It's just this kind of folklore, but I've heard that in Japan, they never had a word for hot flashes. They just didn't.
It's rare in Japan.
Yeah.
Yeah. They have different symptoms, a lot more musculoskeletal than we do. But yeah, and culturally,
They eat a lot of
the
soy. They
expression
eat
of
like
menopause.
omega-3s. They have less sugar. They have, more nutrient dense food, right? So maybe, it's our ultra processed food that's driving a lot of the dysfunction in our microbiome and insulin and inflammation. And so these are things that happen below the surface that most people don't realize, but that are actually driving a lot of hormonal dysregulation. So do you think that, do you think you have a perspective on that?
I definitely know that culturally, and cultures tend to eat a certain way, tend to exercise. Of course, there's outliers and everything. We see a different catalog of symptoms. People who live in the blue zone tend to have less obvious menopause symptoms. I mean, every woman is born with a finite set of eggs, right? And we're all going to run out, and that's our menopause. And then we live 20 to 30 years without the, benefit of the estradiol produced in our ovaries. But how our body reacts to that loss of estrogen, that's where, in my practice, we call it the menopause toolkit. Replacing hormones is one prong there, and it's not for everyone, but we go hard on nutrition, movement, stress reduction, sleep optimization, things that they really didn't teach us in medical school.
Right. And those are true. Those are key. And I think those can get you a lot of the way there. And I think that some things that also are relevant that are things we're also not taught in medical school beside nutrition are things like environmental toxins and how they disrupt our hormones. They're called endocrine disruptors or the microbiome and hormones. How have you sort of learned about those things in relation to the sort of epidemic of hormonal dysregulation, including infertility, PCOS, and all these problems we're seeing?
I think we need so much more work in this area. Just like you said, putting Band-Aids on everything without really looking for, and I know this term is misused, but the root cause, why is this happening to this woman? Like you said, God's not that mean. There's certainly outliers, but why is 20% of our population, 10 to 20% have PCOS, polycystic ovarian syndrome? Why is that? We were not designed for this to happen this way. We were designed to have a very predictable monthly ebb and flow of hormones until perimenopause. And then, and so why is it that that's happening? And I think we need so much more research in this area. I think it's a traffic circle with environment, some toxins, nutrition, everything is feeding into this negative feedback cycle.
And so what are the ways in which these various environmental factors affect women's hormones, and how does it affect them in their 30s, 40s, 50s? Can you kind of walk us through how you think about this?
So when we reach perimenopause, we reach a critical threshold of the amount of eggs that we have, that the normal signals that come from the brain that tell the ovaries to ovulate. What doesn't happen in PCOS, right? We almost become PCOS-like in perimenopause because our level of egg supply at 30, we're down to 10% of what we're born with. By 40, we're down to 3%. And so peri begins when the normal signals don't work anymore. We become resistant. Now, we can definitely make that worse with, we know, if you have inflammation in the abdomen through surgery, chemo, radiation, that definitely helps. If you are insulin resistant and not managed, with diet, that will definitely contribute to how your ovaries are going to respond to this environment and how they're going to produce the hormones. I have less training and stuff on the exact toxins. I know the usual things like radiation and chemo will affect, but if those things affect, certainly others might affect as well.
Yeah. There was a book I read years ago called Hormonal Chaos by Theo Colburn. It was sort of like a Silent Spring book. I encourage you to check it out because it really describes how, she was a sort of research scientist who was looking at what was going on in animal populations and the ways in which these pesticides and plastics and so forth that we're all poisoned with are endocrine disruptors and are causing abnormal genders and hermaphroditism and infertility and, trouble with all sorts of populations from frogs to birds to alligators. And it was fascinating. And I kind of got me to really think about it. The thing that I think that happens with this changes in the eggs and the cycles and the hormones is interesting because as and I'm practicing, what I would notice would be often women would have high levels of estrogen and low levels of progesterone. They would have and what we call anovulatory cycles. This is like what you get in PCOS, where you don't ovulate every cycle, and then you don't make progesterone, which is what happens in the second half of your cycle. And that was sort of the thing that led to a lot of these symptoms of fluid retention and breast tenderness and premenstrual migraines, and then heavy bleeding and irregular cycles. And it's just this big kind of almost continuum of hormonal dysfunction. And and I wonder sort of what your perspective is on this sort of phenomena that I think is a lot, in the world of functional medicine. We talk about estrogen dominance or estrogen excess or imbalance, and it's not. It could be in a relative or excess, relative or absolute imbalance between estrogen and progesterone, and that seems to what's led to a lot of the symptoms and a lot of the toxins and a lot of the dietary things drive an increase in estrogen, right? So these are estrogen mimicking toxins, and then sugar causes fat deposition, which leads to excess estrogen produced in the fat tissue. So can you kind of walk us through what is this whole phenomena? How should we think about it? And what can women start to do to kind of address it?
I think you hit the nail on the head. These are most of what you would call estrogen dominance is chronic anovulation or oligoovulation, meaning you're just not getting that monthly ovulation cycle going. And so, in PCOS and peri, people will ovulate in PCOS occasionally, right? It's very, very similar in multiple levels to what a woman's going to go through in perimenopause as far as where her hormones are. So we have much higher levels of FSH because the brain is constantly trying to get that egg out, to get those estradiol levels up. So that spurt in FSH will then give you these much higher estradiol levels than a regularly ovulating woman would have. And then after ovulation, the progesterone never quite gets to where it used to be. So yeah, she has this whole cascade of symptoms: heavy periods, light periods, no periods, too many periods, everything's on the table as far as her cycles, breasts become enlarged, fluid retention, gut microbiome becomes disrupted. And, treatment options through that really vary from patient to patient. There is no one size fits all. So this is where I think a lot of patients are getting frustration. A, they're not being offered any treatment at all because you haven't not had a period for a year,
Yeah.
or
Yeah.
they're just, occasionally a birth control pill might be helpful in certain situations, but it should not be, I don't think, the panacea go-to for all peri and PCOS patients. By, our lack of training and education around how nutrition, how diet, looking at what she's eating, when she's eating, how she's moving, making sure, she's getting the right kind of exercise. Most of my practice focuses on, 35 plus in that perimenopause to menopause range. And, we're plotting out a course to decrease the risk of osteoporosis and sarcopenia. So that's where my exercise recommendations are going: more heavy lifting, less intense cardio, more zone 2 training, and how, we can balance her hormone levels through this transition so she's not suffering.
Yeah. And so there's things that raise estrogen and there's things that kind of reduce ovulation. So it's sort of like working on both ends of that, right? Um, and a traditional OBGYN will typically just give women, if they're premenopausal, the birth control pill, and if they're
And that's what they're trained
postmenopausal,
to do.
yeah, that's what we're trying to do. It's like, and yet, if they're not looking for contraception, and we can discuss the pros and cons of the pill, but it may not be the best therapy because it comes with risks and also side effects. So, one of the things that one of the things that I did when I was sort of early on in this field was like 1996. I met a guy named John Lee. Have you ever heard about this guy? And he wrote this book, and it's interesting to get your perspective on this. He wrote a book called "What Your Doctor May Not Tell You About Menopause." And
I've heard of the book, but I haven't
it's
read
a
it.
great book. I heard him speak and I was like, this is interesting. Let me try this out. And essentially, he was talking about the use of low dose topical progesterone or sometimes oral progesterone as a way to help a lot of women with all these symptoms that happen, whether it's
In
PMS,
perimenopause, it's very effective.
perimenopause, for sleep, for hot, for
Sleep.
just heavy bleeding, for fibroids, all the stuff that and it was not something I learned in medical school. So how do you think about this whole sort of approach of using progesterone, and is it safe? Is it effective? What should we be concerned about? And how do we sort of know when to use it?
Great question. I really, really like it in early perimenopause, especially if she's still kind of cycling regularly, but she's having disrupted sleep. I love it for sleep. I love it for regular and heavy periods. It does wonders. Traditionally trained, you don't need progesterone if you've had a hysterectomy, however, I use it all the time because what it does for the brain in sleep is amazing. And there's new data coming out looking at, we have a 40% increased risk of mental health disorders through perimenopause when she was completely either worsening or new onset of mostly anxiety and depression. And progesterone can be very helpful here. Also, a low dose estrogen can be really helpful here as well, even if she's still ovulating, something like a low dose estradiol patch, just to kind of shore her up through those dips. That's how I explain it to her. Now, as far as how I prescribe progesterone, transdermal. So we have progestogens, which is the big category, right, of all of our progesterone type medications. We have progestins, which are, quote, synthetic, and I like having options, but I usually do oral micronized progesterone. The topical progesterones are natural, but it's a really big molecule. And there's not great data showing we get enough penetration through the skin if you're giving estrogen at the same time to protect the lining of the uterus. And I really like giving that pill at night for sleep. My patients love it. They really, especially if they're sleep disrupted outside of hot flashes, and my personal bias, it is the best thing I've ever done for myself is the progesterone at night.
It's kind of a miracle. It was kind of a miracle pill and a miracle drug that I never learned about really using in medical school other than in combination with Premarin and the synthetic form of it called Provera, which my joke was it made women fat, hairy, and depressed because it had a lot of side effects,
So,
and
not many of us in the modern menopause space use Provera, very, very rarely. I pretty much just use progesterone. I'm trying to give the patient as close to what our ovaries used to make as possible. I don't love the term body identical, but it is body identical. So,
but I think that's a really important point. Is to use stuff that your body knows what to do with, and it doesn't have all these untoward effects. Like, and I think the thing you said, I just don't want to skip over it. Is that you're doing something that's really unusual in women's health. You're actually combining topical low dose estradiol or the most common form of estrogen with oral or even topical progesterone, and you're doing it before they end their menstrual cycles, before they technically have the definition of menopause, which is really kind of a little bit heretical. It's like
I just refuse to let people suffer.
That's it, right?
Not only, but the data is clear, Dr. Hyman, on mental health, you are better off giving her balancing those hormones than giving her an SSRI. It is more effective for the perimenopausal patient with new onset mental health changes. So, and then the cardiovascular data is looking good. If we can get this thing shored up before she completely transitions, she is going to do better in multiple aspects of her life. Why are we waiting till people are symptomatic? Why are we waiting until they have osteoporosis? Why are we waiting until they have genital urinary syndrome when we could be preventative?
Well, what do you mean? That's what we learn to do in medical school. Wait until someone's sick and then give them a drug. I don't know what you're talking about. It's so totally clear why we do this. I mean, what you're saying it sounds so common sense, but it's often sort of not how we learn and how we practice. And I think what you're talking about is something that's so rewarding, because for anybody listening out there who's a woman or who lives with a woman, you understand it's not always fun, and there are solutions, but often the solutions are not getting to the people who need them because of the way in which traditional medicine is practiced and how we're trained. And yet the solutions are relatively simple, very inexpensive, and very effective. I mean, I would say, other than like delivering a baby, which is so fun and a positive experience, giving someone hormones and having their life turn around is like one of the most satisfying things as a doctor, right? Because you're just
I
doing,
100%
you're just
agree.
like, they all of a sudden they start having symptoms, their sex drive comes back, their energy comes back, they don't have mood changes, they have all these benefits, that occur. And we went through this period. I want to sort of come back to this because there's a reason we've sort of shied away from hormones and women are suffering is that hormones kind of had a good rap and then a bad rap. And now they're coming back to having a better rap. And I think there's a historical reason for that, which was the Nurses' Health Study that was an observational study that didn't prove cause and effect, but the women who seemed to take hormones did better than the women who didn't. So everybody was like, you got to take them. And I remember a woman in my practice who said, at Kenya Ranch, she said, if I don't take hormones, my doctor says it's malpractice. If you don't prescribe hormones, it's malpractice. And that was the Nurses' Health Study. And then it shifted all in like 2002. There was a Nurses' Health Study, and it was like, went to the Women's Health Initiative, which was a big study of $1 billion and 40,000 people, women. And it kind of gave us some country data. And that meant like 50 million women overnight stopped taking it, and it led to sort of a catastrophe. So can you walk us through, like, what should we actually know from the Women's Health Initiative, which is a randomized controlled trial, and what do we know now that's different in the intervening 22 years that has changed our thinking?
So this was one of probably the best cases of something going viral before social media. And kind of this path of misunderstood information or misinformation. So WHI, they started enrolling patients in the late 90s. We knew from observational data that women on HRT tended to have less heart attacks and die from heart attacks less. And so they said, all right, well, is it just because women on HRT are healthier and wealthier? Is this an artifact? Or can we prove this with a randomized control study? First time aging women had ever been studied with that level of, and they used Primin and Primpro, which at the time were the two top. That wasn't unusual at the time. Those were the two commercially available formulations that they did. So that's one problem. They used one formulation. The Premarin if they didn't have a uterus, and then Primpro if they did, versus placebo. Average age. So the outcome of the study was not safety. It was measured, but that was not the primary aim. The primary aim was to see if they would get cardiovascular disease or not. So they started with a much older population. This is key. The average age of the study was 63. They enroll the patients, get started. In the Premarin and Provera arm, they did notice a very slight relative risk increase of breast cancer in that population, not in the estrogen-only arm. They called a press conference. They didn't release the study data at the Watergate Hotel, and it was on the cover of every newspaper, every news story. I remember, I was my chief year of training. 2002 was when I graduated. And it, like you said, it was this massively disruptive. It was the top medical news story of 2002. And it said estrogen causes breast cancer. Well, turns out the estrogen only arm kept going and they didn't see an increased risk of breast cancer. So now, but that notion just went crazy. No one would prescribe it after. Everyone was terrified. Those data points have been refuted, as you know, throughout multiple studies throughout time, but we're just having a hard time like getting the world to catch up to this. But in general,
was it the forms of hormones that caused some of the increased
right?
stroke
And so, Levy and Simon and Levy just published like the contemporary view of hormone therapy. Formulation matters, type matters, age matters. We have a window of opportunity for protection for cardiovascular disease, and basically, it's the time away from estrogen where the problems start for females. So the longer my body is away from estrogen, the more likely I am to have a stroke, cardiovascular disease, diabetes, every cardiometabolic disease. Estrogen is protective. Once those diseases start, estrogen is great at prevention, not a cure for some of these things. And so the older women in the study didn't see a cardiovascular benefit because they probably already had heart disease. They missed their window of opportunity because they started older. Their acceleration of their diseases had already occurred. So now we know if you want the cardiovascular protective benefits, you probably should start within 10 years of your menopause. If you want the neurologically protective benefits for decreased Alzheimer's and dementia, you need to start within the first 5 to 10 years. Lisa Mosconi has new data published on this just this week in Nature. Probably it's a bigger window than we thought. if it will always protect your bones, it's always going to protect your genitourinary system, it's always going to protect your muscles, but you still have to do the work. So I never want any of your listeners to think, oh, I'm just going to take hormones and go about my
Yeah,
day
you
and I'll be
can.
perfect. No,
You still got to exercise.
no, you must exercise, you must eat right. This is a tool in the toolkit, so that, because here's the fact of the matter: women live longer than men, sure, okay, but we spend 20% of our lives in poorer health than our male counterparts. And that's not okay. And that's the gender health gap. And that's where this is where the work needs to happen.
Yeah, I think this is so essential. And I think, as I was sort of learning about the Women's Health Initiative, I actually already had kind of gotten a little bit biased because I'd read this book about bioidentical hormones, about using hormones that were the same as your body's own hormones to bind the same receptors that had less side effects, like Premarin, which was used in that original women's health study. That actually has to be metabolized by the liver, and it actually increases inflammation, C-reactive protein, increases triglycerides, increases your risk of breast cancer, I think, because of its effect on alcohol metabolism and lots of things. So if you drink a glass of wine, your hormone levels would jack up really high. So I think there was a lot of problems with that. But now the topical or bioidentical hormones seem to be better tolerated, more effective. Are you worried at all about them? Should we be concerned that there is some unknown risk that we haven't determined from the research yet about whether or not these actually may increase breast cancer risk or ovarian cancer risk?
Not in the estrogen family. Not if you stick to not in the estradiol world. Okay, it doesn't look like it's actually protective for breast cancer, especially if you start young. The progestin seem to be where there's a lot of variation, and these studies are being done. We have lots of data coming out from Europe and other places, but they're all using different progestogens. What I want to see is a head-to-head of estradiol plus my oral micronized progesterone, and let's follow those women, for 20, 30 years and see who lives
Yeah.
longer, what the risk of breast cancer is,
Right.
et cetera. But, what's happening is bikini medicine in my world, where women are little
Bikini
men with
medicine?
breasts, with bikini medicine. So the only thing we need to worry about in women's health is the bikini area, the breasts and everything under the bikini. And so, the bikini bottom. And it's like you said, we're not testing these drugs, cardiovascular drugs on men. So let's take a statin, my cholesterol went up through the menopause transition. I've been able to get it back down with HRT and diet, okay, very successfully. But my doctor recommended a statin. There is no data to suggest that statins decrease the primary risk of a heart attack in women. HRT does, and that was actually Premarin, like not the best of our options out there. So, I could go on and on about this.
No, it's good. It's good. It's good. I think it's good because I think, we have to sort of empower women with the knowledge that we have now and not be stuck in this old story that we shouldn't do it. Now, the question I have really is if you're going through menopause and you have no symptoms and you're good, should you take hormones?
I would have a balanced conversation with that patient, and that's what I do in my clinic. I'm going to talk to her about, even though it's not recommended by the societies yet, except for the American Heart Association. Well, they're a little bit on the fence, but I talk to her about the known protective benefits of hormone therapy, her bones, her brain, her heart, if she's in the right window of opportunity. And I'll let her make a decision for herself. We'll talk about the risks, her family history, her needs, her wants. What's happening is the old menopause was HRT only for the shortest time, the lowest dose, only if you have severe symptoms and you're going to jump off a roof. Okay. But what about the woman who kind of, luckily the 15% who don't have the cliche symptoms? But I also say, what's your cholesterol? How's your insulin resistance? How's your joint pain? Because those symptoms are just now being recognized as part of the hormone deficiency that's going on.
Sure.
And maybe we can help those things.
Yeah. And so to flip the question upside down a little bit, if a woman starts on hormones, is this something they should stay on long term? And is this something that all women should do after menopause? Is this something we should kind of move towards thinking that all women should be done, or is this more of a personalized approach?
I definitely think it's personalized. Right now in the US, 4 to maybe 8% of women who are eligible are on HRT. And people are saying that's over medicalized. And I think that's ridiculous. We're just allowing your body to work in the fashion that it used to work before you went through this change. And, before you lost your eggs. And So I think every woman deserves that conversation and to be allowed to make a decision for herself. And then if she decides to do it, I review it every year with them. How are you doing? How are you feeling? Have we developed any new medical problems? But it is absolutely possible that a woman could enjoy benefits of hormone therapy until she dies. I might die with an estradiol patch on. So, and but that's my personal choice combined with my knowledge level and my family history.
So I'm hearing the subtext, unless someone has significant reasons not to, like breast cancer risk, or they've had breast cancer and it's contraindicated, or ovarian cancer, or uterine cancer, which are hormone dependent cancers that do flourish in the face of
that
estrogen.
Would feed your cancer would be fed. Yeah.
Right. It seems like what you're
a severe liver disease, a recent blood clot, and a recent DVT or PE. Mm-hmm. So really contraindications, of course.
Yeah. Mm-hmm. But for pretty much everybody else, what I'm hearing you say is it's a good idea.
It's something to consider, and it is something I discuss with every single patient.
Yeah. The other thing is, women might have a sort of like the frog in cold water that gets turned up slowly and they don't know they're boiling to death. Like the changes can happen and be subtle, and you think this is just a normal aging, but then you get them on hormones, like, oh, wow, this is a different me, right? And this is a whole new experience.
That is what I see in my clinic, and that is what the Menopause CC, we have this little friend group of clinicians, and we're multidisciplinary. The Menopause. And we text all day long. We share patient stories and ask questions and articles, and, it's fun. And so, it's retrospective. It's all these women saying, oh my gosh, I didn't realize that my tinnitus, my vertigo, my palpitations went away,
Mm-hmm.
Yeah. It's pretty exciting. It's exciting stuff.
So let's talk about testing. What I found is hormones fluctuate greatly. And, when I was sort of in medical school, we were trained, don't worry about testing so much because they're all over the place. And, you only want to test after they've stopped having their period to confirm they're in menopause. How do you see testing hormones in women, and when should women start testing? What should they be testing? And if you're checking hormones, does it matter when in the cycle you're testing? Like, should it be day 1 to 3 or day 18 to 23 to see what's happening with ovulation? How do you sort of think about this?
Here's my fantasy is that we have a CGM type thing, a CHM, a continuous hormone monitor. Why not? Why not? There's actually, I talked to someone who's trying to develop one where you start having symptoms, you pop that bad boy on, you follow yourself for a couple months. It's tracking all the things, your estrogen, your progesterone, whatever. But, we have these kind of poor panaceas for that right now in the form of, you need to do testing over multiple days. It's hard to read. And so the way I diagnose perimenopause is I talk to the patient. I absolutely believe her. I do a lot of blood work to rule out other things like autoimmune disease, hypothyroidism, inflammatory disorders, nutrition. But like a spot hormone test because of all that crazy chaos is not going to help me that much. Certainly if I can't use her period to help kind of guide me a little bit, I'm doing hormone testing, to see, is she really postmenopausal and we missed it? Because we don't have a period to judge. But I don't have a great, easy blood, urine, saliva test that I think is 100% reliable. I really just listen to the patient, believe her, go there with her, make sure nothing else is going on or overlapping with all the blood work. And then we just dive into treatment.
It's interesting for premenopausal women, I think, who are having a lot of symptoms. I always found that if I checked hormones sort of in the second half of the cycle, like day 18 to 23 of a normal 28-day cycle, that I could see what's going on with their ovulation because their progesterone would often be low.
Progesterone would be low.
And their estrogen would be really high. And that would kind of give me a lot of clues about what's going on. And then I might just try progesterone with those women, or I might try that and a tiny bit of estrogen. And that seemed to be a good sort of indicator. Is that a good practice?
That's very reasonable. If you can get it on day 18, just with modern, we are lucky in the type of clinics we had, but sometimes, the access that patients have to that kind of thing is pretty limited. Yes. But I think, a really high estrogen with a really low progesterone is classic anovulation, right? Or oligoovulation, that's either peri or PCOS for us. And, giving her progesterone often is miraculous for those patients. They're so happy.
And you can always see the ratio of LH and FSH change, where you get high LH and low FSH, which is often correlate with PCOS. So we see that too.
PCOS,
So it's
yeah.
kind of
Mm-hmm.
what about, early on in the cycle? When is it indicated to do testing day 1 to 3? Is
So
it for
typically, most of
fertility or
what
for
I learned that was for fertility. And interestingly, fertility does a lot of work with AMH and
anti-Müllerian hormone?
anti-Müllerian hormone. They're actually looking at analogs of that, or I think they're blockers. There's 2 biotech companies that I know are working on, medications that work with AMH to extend the life of the ovary, because it seems that rise in AMH is accelerating the loss of the follicles in menopause. And if they can figure out a way to block that process, they think they can extend the life of the ovary so that we can enjoy more of our natural estrogen. But again, that's all in theory, and they're testing it in
And if you
animals right
measure
now.
AMH, it should be lower in order to indicate better fertility. When it's higher, it
Right,
might
which
be a clue
means
that
you have a longer time until you're menopausal. So I think there's a lot of work to be done there in the menopause space. So I'm excited to see what's coming in the future for that.
Let's talk about sex. I think, one of the things that I've
We didn't talk
found is,
about testosterone yet.
no, that's what I want to get into. So, you've said before that, and this is sort of well known if you're a physician, is that maybe not actually, most doctors, is that absolute testosterone levels are higher than estrogen and progesterone levels in women.
In women, it's the precursor to estradiol down the pathway to create estradiol. Testosterone's the last step before we aromatize it to estradiol. So yeah, our natural testosterone levels are actually higher in picograms per deciliter than our estradiol levels. But then we lose those too.
Yeah, and there's a lot of reasons for libido issues and sexual dysfunction in women. I once heard a woman, Susan Love, who wrote a book about women's health years ago. She was quite amazing, and she said the biggest sex organ for women is between their ears, and I think there's a lot of truth in that. But also, women have vaginal dryness, they have lower testosterone, they have arousal dysfunction, there's all sorts of stuff that gets kind of ignored.
Orgasmic dysfunction,
yeah, and and men got Viagra and all this stuff, but women kind of don't really seem to have this addressed very effectively. And what I found is that it can be really effectively addressed by addressing overall lifestyle issues and relationship issues, obviously, but sometimes using testosterone can be very effective. And it also is great for bone health and mood and energy and focus, and has a lot of benefits. So I'm curious about your perspective about the use of testosterone and how you use it, how you prescribe it. I one of the things I learned was that you could use it topically on the clitoris, and you can get it compounded. And if women use a couple of drops every night, over a few weeks, it really increases their arousal, orgasm. And I think it worked, because the women I prescribed it for would always call me back for refills. So I figured that it was working.
Yeah. So my friend, in our menopause, we have 3 or 4 urologists who are females, they're in Ishwish, the sexual medicine wellness conference. And they love topical testosterone in the vulva, especially if they're there's so many testosterone receptors in that lower, in the introitus as well. They love it for the clitoris too. So like doing that, if you look at the vulva, that they call it 12-6 when you apply the cream, and they have it specially compounded for that. They're huge fans of that. Especially if they have GSM, general urinary syndrome of menopause, a combination of estrogen and testosterone, or the DHEA, which gets converted down the pathway to both, is helpful. So I love testosterone. I'm a huge fan. Clearly, the data for HSDD, hypoactive sexual desire disorder, which is the organ between our head.
Oh my God.
It's that, but does she have a good relationship?
Doctors like to give these names.
Yeah. Is she having pain? We're ruling out all the other causes, making sure she has a stable relationship with a partner who she used to have a good libido with, or, layman's term libido, making sure she's not having pain. We got to fix that. And, so all those things are addressed. And then testosterone really does seem to be helpful for the hypoactive desire issue. So the brain part for females. Also, I use it off label if my patients come in. I have a monitor in my office for muscle mass and visceral fat. I have an in-body scanner, electrical impedance scanner. So if she's coming in and she's had a bone density and she's got low bone mass and she's sarcopenic, I am recommending it off label, because the data is very promising in combination with, we know that women with higher just natural testosterone levels have less of those diseases. So I'm just trying to help her, but she's got to eat the protein and lift the weights and do all the things as well. And that testosterone can be additive in that.
And you use it topically, or how do you use it? Through the
I
skin
do.
or
So yeah,
shots or?
or only undecanoate is, and it's not even approved in the U.S. is safe, for the liver toxicity part of it. So testosterone therapy should be transmucosal or transdermal for safety reasons. And then in the U.S., there's no FDA-approved, formulation for women. So in some states than others, it's easier to get. Sometimes you can do the male version of like T-stem gel, but it's hard to dose. It's like a pea size amount, or so most of my patients, because Texas, we really have a hard time getting the T-stem from the pharmacist, will go around the block and do a compounded cream. So I'll do a transdermal testosterone cream for the patients, and we'll kind of dose adjust, based on her levels and her symptoms.
And it doesn't cause women to grow mustaches and beards. And
if you stay in a
get
physiologic
husky.
range, if you don't overdose her, sure, if I give her enough, she will grow all sorts of things. But I try to keep my patients in a healthy physiologic range.
I think that's so important. That is such a key statement, and it is to use hormones in a way that kind of matches your normal physiologic state for optimal health, not an excess amount. I mean, you see these muscle heads in gyms that have huge levels of anabolic hormones that just are super physiological, and there are serious consequences to that. But if you're keeping people in an optimal range, it actually works. And I think, again, this is one of those areas that has been neglected for women that is so important to be addressed. And again, even that there isn't an FDA-approved formulation, that you have to go hustle around and try to get this prescription covered or go to a compounding pharmacy, just doesn't make any sense, right?
Exactly.
It really doesn't.
It's so frustrating as a clinician that I can't. It's so complicated sometimes to help my patients get what they need just to feel normal again.
Yeah, I think we're kind of hopefully coming out of the dark ages of women's health. I don't know if we are, but it feels like there's a lot of people out there now talking about it. There's you, there's people like Sarah Gottfried, there's others, my friend Gabrielle Lyon, are all kind of advocating for kind of a new way of thinking about women's health. It wasn't something I intended to go into, but it just became something that I was very much immersed in because of the population that I was dealing with. And I just learned so much from my patients. And, and often the best source of learning is listening and asking what's going on with them telling you, and then learning about the condition and how to sort of adjust your treatment to match that. And I think, it's been a dark period because of the Women's Health Initiative. There's been such a fear and such a resistance to hormone therapy across the medical disciplines. And now it seems like it's shifting. Is this just on the fringe, or do you think this is changing within traditional obstetrics and gynecology?
I definitely see it changing. I see, like, in the American ABOG, American Board of OB-GYN, the Council on Resident Education. I was a program director for like 10 years. So they are pushing to have a menopause curriculum. I see, more and more people contacting me, other clinicians who are like, help me, I want to learn more. The rate of people signing up to get certified by the Menopause Society is skyrocketing. I think people are becoming aware, mostly due to social media platforms, the news, and patients. This generation of menopausal and perimenopausal woman is not putting up with it. She knows there's a better life for her, that she doesn't have to suffer, and she wants more information.
So what's on the horizon? Like what are we kind of looking at in terms of, new advancements in medicine, in nutrition, supplements, in other therapies that could help with women's health and hormones and menopause? Sort of you're kind of on the leading edge and you're hearing about things that are emerging. What are you excited about?
Well, I talked about the ways to like improve the shelf life of your ovary naturally, to like hang on to the follicles that you have for as long as possible. So that's one of the most exciting things. Two, my daughter is a medical student. She just started her second year like this
mine
week.
too.
And yeah,
mine's in their fourth year.
It's really exciting. And she just seeing her class and how excited they are about learning more about menopause and aging women, males and females, all the people in her class, how into this that they are, and they see the tide changing. I'm like, this is the next generation. They're going to be doing my surgery in 20 years. Like, and that what I see is other medical society really starting to put a toe in the water and study the aging woman outside of what a man does, and like how that's just going to broaden our understanding so that we can close that health gap between men and women.
Yeah, that's great. I mean, I think there's some kind of cool therapies out there that I've seen, like certain things for arousal disorder, like Vyleesi. There's other
Oh
drugs out
yeah,
there?
Addie and
Are there
Vyleesi are pretty cool. So yeah, Vyleesi for HSDD. Yeah, so there's two FDA approved medications for the treatment of hypoactive sexual desire disorder. They were studied in premenopausal patients, but we are using them off label for menopausal patients. So Vyleesi is a medication that works on melanocortin in the brain, and it's an injection you give your yeah yeah. So injection you give yourself 30 minutes before activity. And when it works great. Like the patients absolutely love it. And similar to how Viagra would works because you need a certain time before the medicine kicks in and the arousal, begins. And then Addie is a medication you take every day, and it works at the level of neuroreceptors in the brain, changing. God, is it dopamine? I can't remember. I should know this. And so that's a medication you take every day, like a vitamin, to just kind of shore up your levels so you're more interested and ready when the opportunity presents itself to you.
Yeah, it's great. It's great. I mean, I think it's about time. And I think the other thing I wanted to sort of just before we wrap, I wanted to talk to you about PMS because in my experience, seeing women in this sort of transitional period, it gets worse. Like it may not
Mm-hmm.
be bad in their 20s, and then in their late 30s, 40s, it starts to accelerate, and they get premenstrual migraines, they get fluid retention, they get breast tenderness, they get mood changes, they get sleep disruption, and to me, it's sort of like almost like kind of squishes up against the sort of whole perimenopausal phenomena because it's often related to this imbalance that you get in hormones from the lack of ovulation every cycle. And I'm curious about how you approach that and what you think about that.
So I know from her history, if she had severe PMS symptoms, and we go through what those were, that these tend to become accelerated when she hits perimenopause. That whatever pathology was causing that, how her body responded to that hormonal milieu in her body. This is gonna especially if she has depression or anxiety. She had to be treated for that. We know that I need to be on the lookout in peri that this may be the first sign of her perimenopause that she has sudden worsening of these symptoms. And I'm going in for hormone therapy very quickly on that
So
patient.
as a treatment for PMS, you use hormone therapy,
So
meaning
it's been a while. So now not doing a lot of premenopausal patients now, but back in the day, we kind of had two options, like squash her hormones with birth control pills. And for some that gave them symptomatic control, or do an SSRI, either every day or
Serafem,
just
otherwise known as Prozac.
two, two, 2 weeks out of the month, when her PMS symptoms would have been the worst. But as far as like any real research as to why the hell this is happening, other than you're just a woman, we got work to do.
Yeah, I mean, from my experience as a functional medicine doctor, it seems pretty clear that it relates to a lot of the lifestyle factors, environmental factors, toxins, diet, the gut microbiome that are all modifiable. And then by fixing all these things, get people's nutritional status up, give them B6, magnesium, a lot of the things that help omega-3 fats. A few supplements often can really be helpful. In fact, I had a cocktail, they don't make anymore, but it was a cocktail of Chinese herbs that's for perimenopause and hormone imbalance and PMS, and magnesium, taurine, and B6, which all help with estrogen excess and metabolism. And it would be like a miracle pill for this. Also, I use chasteberry, which is an herb, Vitex, can be
Oh
helpful.
yeah, Vitex.
And then, sometimes giving even a little bit of progesterone can be really magical for these women, even topical or oral if they need a little more. And so it's really about getting the whole person healthy. And I think, it's easy to think of jumping to hormones, but I think what you said before was really important, that it's not about just jumping to hormones. It's about understanding the full panel of phenomena that are driving these changes and then working on those, what you're eating, exercise, stress, sleep, nutritional status, your gut health. All these things will help to regulate your hormones because they're influenced by all these things. And that's sort of, they're not just randomly going haywire. There's reasons for it. It's not, like I said, a design flaw. And so we can actually really do a lot of good for people by helping them do that. And by the way, the side effects of all those things work for every other known disease. So it's
Right.
like,
And so
it's like,
when I give a lecture to medical students and residents, thank God programs are inviting me, and I go through the menopause toolkit, and we talk about the big six: insulin resistance, cardiovascular disease, and how menopause plays in here. And I'm like, you're going to see the same things repeated 25 grams more of fiber in your diet per day, lower your, get adequate sleep. I'm like, all these things work for all these diseases, right? And so you're going to see a pattern here, and there's a reason for it.
Yeah, it's not like there's one diet for preventing cancer that causes heart disease, another diet that's for heart disease that causes
Right.
diabetes, another diet for diabetes that causes dementia. No. It's like the basic principles of running and operating a human being are pretty the same, right? In your car, you need oil, you need gas, you need air in your tires. Like, it's not that complicated, but it's, again, stuff that we just don't know anything about. I mean, my daughter's in medical school, and I said, Rachel, how much you learning about nutrition? Nothing. I learned about fatty acids and amino acids, and I'm like, what are you going to tell your patient to eat for lunch? What are you going to eat for lunch, right? And then I said, well, what about your microbiome? Well, not really. How about toxins? Well, no, not about that either. And I'm like, wow, it's even though, the science is out there and it's not hard to find. You just go to the internet, you can go to PubMed and search for anything and you'll find it. And you'll find what data on there.
My daughter got her undergrad in nutrition science.
Oh,
and
wow.
She was going to become a registered dietitian. And then like halfway through, she's like, Mom, I think I want to take the MCAT. And I was like, go for it. She thought she could be more effective with her nutrition background going to an MD than an RD. Is more of her interest level. So yeah, she talk about, whenever I talk about nutrition, she follows every word and double checks me and is throwing articles at me. She's really fun having her, double, triple check everything I say.
Yeah, well, they're good to kind of keep you on your feet, right?
Yeah.
Yeah. So if you could kind of have a final word to women out there who are struggling with menopause and menopausal symptoms, perimenopause, PMS, like what kind of sort of would you advise them as a sort of an overall sort of menopause framework and strategy? Kind of how do you kind of
menopause is inevitable for all of us, but suffering is not. And you can live your best life. I am almost 56. I am the healthiest, happiest, best relationships, beautiful sleep, multiple reasons for that. It's not just an estrogen patch I'm wearing. And I want everyone to feel the way that I feel right now. I want everyone to enjoy the life that I have, and I changed everything when I hit menopause. I changed how I ate, how I thought, how I stress released. I gave up a lovely job that I cared about that was killing me, and,
right.
So I want that for everyone. And so, finding a menopause educated provider, to help guide you through this and be your partner through this transition is going to be key.
Well, thanks for your advocacy and your work and your insights. You have a wealth of resources. Your new book is really tremendous. It's really
Thank you.
Kind of lays out a map. It's for women. It's called The New Menopause, the latest research and best treatments for a healthier, better life. You can find everywhere you get books. You also have a great website, right? And it's
Thank you.
Maybe share what that is with everybody.
Yeah.
Menopause
Life. Yeah, it's thepauselife.com.
The Pause Life. That's great.
Yeah.
That's great.
I wanted to put a positive spin.
Great. And so I think it's just great that you're out there talking about this, because it's not enough people, particularly from more of a traditional academic background, who really understand this and are helping people through it. So thank you. And it's great to hear that you and I come to the same conclusions after 30 years of practice. So I really appreciate your work. And thanks for joining us on The Doctor's Pharmacy.
Thanks for having me.
If you love that last video, you're going to love the next one. Check it out here.